We'll try to get started and get through this. We're going to talk today some protocol revisions to the to our standing orders and also a couple of new concepts that are in the protocols as well. This probably won't be the only protocol revision in the next 12 months, but we'll sort of work things in slowly. Some of the things we're going to talk about today won't come into effect for about a month. It takes a while to get these done. I'm going to have to peer around a little bit. I had a cataract done a couple of weeks ago, and I still haven't quite adjusted to the changes. Yes, it was only on the left eye. It was pretty interesting. I showed up to have it done, and the nurses come in, the anesthesiologists come in, they do all the stuff, and they said, "Oh, we're going to put a big green dot above the eye we're going to work on." I said, "Well, that's fine. I know you have to do that. That's protocol. But you know, if I wake up and I find that you're operating on the right eye, we're out of here. You know, it's a different thing." So. Okay, first thing to talk about, a new concept, and I'm sure that'll throw a couple wrenches into the way you do things now, and you're concerned about it. But this is the pediatric thing, and it's a new, pediatricians deal with small things, so they have to come up with a couple of new ideas and new rules. But this is a very important one. It turns out, when you look at the statistics, that it's highly predictive of serious problems. And it's called an ALTI, or apparent life-threatening event. And the definition is an episode that is frightening to the observer. The observer is the parent, or a babysitter, or the grandparent, which is even more likely. And but it's an item that's very frightening to the observer that the child exhibits. And it's either, they could have a combination of apnea, color change, cyanosis, marked change, cyanosis, or become all of a sudden extremely pale, marked change in muscle tone, choking, gagging. All babies spit up, all babies gag a little bit when they're feeding, or most do, but it's not frightening. The mom says, "Hey, well, the kid choked a little bit." So the parent got really anxious. This may account for up to 7.5% to 8% of all pediatric EMS calls in the infant age group 1 to 12 months. But it can occur at any age up to about 3 years of age. So we're calling an ALTI, that could be a frightening event that occur up to age 3. It's not well established, but you can have up to about, they think it's about 3 per 1,000 births, so that's 0.3%. Mean age is 3 months, 55% being males. Those of you who are thinking ahead on this may say, some of these ALTI events may be preceding what turns out to be SIDS. And that's the reason we talk about this. It's a group of symptoms, not a disease. There's no disease, there's no virus involved, there's no ALTI virus. That'd be a great thing to invent, you could treat it then. As many as 10% of the patients require emergency department or hospital intervention. So they're either intubated in the emergency department or some major intervention occurs. They do all require a workup, in our opinion. So all patients who have what we're going to call an ALTI, it should be transported. Now, your job, our job, is to determine the severity, the duration, and the kind of nature of the event. If the parent and guardian doesn't want to transport, says, oh, well, the child is fine now. That's the problem with ALTI. You show up, there's no problem if you get there and the kid is seizing, cyanotic, apneic, that's not a problem. What happens is you show up with an ALTI, and by that time the child looks okay. And the parent says, oh, I don't know why I called you. So if the parent, guardian doesn't want to transport the child or is refusing medical care, that's an automatic and mandatory medical control contact. Put them on the phone with the doctor. Now, etiology. What's the etiology of apparent life-threatening events? Well, they could be reflux, but they could have underlying cardiac abnormalities, two non-accidental traumas. A certain percent, it's a low percent, but a certain percent of these turn out to be shaken babies. Hospital workup for an ALTI requires a battery of tests, and often gets a septic workup and a cardiac workup and a respiratory workup simultaneously. And often, you don't find a definitive cause, but you become anxious about it. Up to 50% of cases will have a defined cause. 50% are gastrointestinal, and it could be anything from gastroesophageal reflux, which does occur in babies, where the cardium, the sphincter at the diaphragm, will become patulous, very it doesn't squeeze, and the child just refluxes. Could be from abnormalities, congenital abnormalities of the intestine. Could be from congenital abnormalities of the stomach. They can get hypertrophic pyloric stenosis, which babies start vomiting, and then they aspirate when they vomit. 30% can be neurologic or neurogenic in order. So there could be a problem, underlying seizure disorder in the child. 30% of childhood seizures are evident by the time the child is 3 months old. 20% could be respiratory, viruses, pre-aspiration pneumonia, all sorts of things. 5% cardiovascular, metabolic and endocrine count for a small percent, and then non-accidental trauma. Drugs and toxins are very low on the list. They can occur, but it's uncommon that a child under 6 months of age would be into drugs or toxins. If they start crawling early, I suppose. So we're talking about the ALTIs that occur in older age group kid that might have gotten into grandpa's pill. Beta blockers. So in your assessment, in anyone's assessment, the circumstances associated with the symptoms, history of color change, irregular breathing, change in muscular tone, those are the big key things to clue on. Ask if they have concurrent symptoms, fever, cough, rhinorrhea. Have they had a cold recently? Have they had anything going on? Any diarrhea, vomiting, rash, labored breathing? If they have a prior ALTI, if mom says, a week ago he had an episode just like this is a big red flag. If they had one within the last 24 hours, it's a big, big red flag. If there's a family history of SIDS, also a red flag. If the one kid went down with SIDS, another one can too. Ask what treatments, what interventions, how did the kid start breathing again? Did the mom do mouth to mouth? Did they shake the child? What did they do to get the child going again? Was there actually CPR done? Compressions. Premature birth before 37 weeks of gestation is another red flag. Past medical history for an older child, history of seizures, previous seizures, history of injury in childhood, and a history of reflux disease. Exam, kid gets a full set of vitals, even if they're looking okay. Look for signs of respiratory distress. Obviously, grunting, nasal flaring, retracting. That kid is sick at that point. It's not looking okay. You may need to intervene. You do need to intervene at that point. Color, are they pallid? Is there cyanosis? Are they normal? What's the mental status of the child? Obviously, an infant is difficult, but they would be, are they unresponsive? Do they respond to the mom? Are they consolable by the mom? Are they seeming normal? Are they flaccid, tired? Obviously, looking for physical signs of external trauma, ruling out the child abuse cases. Kids should be put on a cardiac monitor, get a pulse oximetry, get a finger stick or heel stick blood glucose. Supplemental oxygen if there are signs of respiratory distress. Now, escalate. We don't want these normal children or children who respond to routine and a routine stepwise approach to the airway. We don't want to go right to intubation. So escalate from a nasal cannula, face mask, non-rebreather, and more advanced airway as needed. Obviously, that kind of a child, when you need to think, gosh, I might have to intubate this baby, you're not thinking you're going to leave this baby at home. And the parent is not thinking that either. These aren't the ones who are going to argue with you. If they have excessive secretions, use a nasal secretions, use a simple bulb suction or a suction catheter if you have to. Place an IV if you have clinical concerns of shock, or if you have to give medication. If the child's having a seizure, obviously you probably need to get a line in there, although you can give Versed IM. I prefer it, and you prefer it to give it IV. Works faster, better control. But a normal appearing child, just because you're going to transport them to the hospital, you don't have to start an IV on that kid. If apnea persists, obviously approach your advanced airway the way you always would do. Bag valve mask first, supraglottic devices and/or intubation. We don't carry many supraglottic devices for little kids in this county. If you need to intubate the child, you intubate the child. But only do that if your bag mask is failing, or if they're apneic and respiratory failure. Least invasive method possible. That's always true with the kids. So, regardless of the child's appearance, you've had an ALTI, you've evaluated it seemed to be a real thing to the parent, to the guardian. All patients with a history of sign or symptoms of ALTI should be transported for further evaluation. Obviously, and we don't even consider, transport any patients with history of cyanosis, significant past medical history, even if they look good. Any past history of an ALTI, a resuscitation attempt by the caregiver, or more than one ALTI in that 24-hour period. Those are absolute, no question at all. And you should go to any ED facility in Clark County has the ability to evaluate and manage these children. Now, no facility, if this child needs to be admitted, particularly to a PEDS ICU, no facility in Vancouver, in Clark County, will admit that child, because the only pediatric intensive care units are in Portland. But we're not going to transport all these children to Portland when they can have when most of them will, the vast majority will have a workup in the ED and be released home. If they need to be stabilized, we stabilize, just like you do with trauma. If we have a critical peds trauma, we will stabilize them in Clark County and transport them as needed. So what's the prognosis of an ALTI? Morbidity, significant illness, and mortality, significant illness, vary according to underlying diagnosis, but the range is 0 for non-significant ALTIs to up to 6% for the ones that are caused by significant problems that we may or may not miss. The recurrence rate of ALTI is 0 to 24%. So about a quarter of the kids you see will either have another event after they are evaluated for the first event, or they will have had, their parent will have said, geez, they had something just like this 2 days ago, and they've been fine ever since. Long-term outcomes for those that have unexplained ALTI are unpredictable. But ALTIs that have severe events requiring resuscitation or an event that's recurring or a diagnosis of a seizure disorder, ultimately, they hold up to about a 25% risk of death. So some of those will turn out to be, it was a SIDS case. Some of them will turn out to be a seizure that will ultimately end up in a respiratory arrest. So your protocol, which has been added, it's F3 in the PEDS protocol, apparent life-threatening event. An ALTI is defined as an episode in an infant which is frightening to the observer, includes one or more of the following: apnea, color change, marked change in muscle tone, gagging, choking. Support ABCs, follow airway management and respiratory distress protocols, place patient on cardiac monitor, consider obtaining blood glucose. Don't consider it, do it. Obtain, that's what we mean by consider. Obtain a detailed description of the event, duration, nature, severity. All patients should be transported to a hospital for further evaluation. Online medical control is mandatory for any patient with suspected ALTI where a parent or guardian wishes to refuse. Now, you may well say to me, Dr. Whitwer, I took this kid in, he looked perfectly fine, I dropped him off at the emergency department, and the ER doc said, you dumb shit, why are you bringing this patient in? This kid looks perfectly normal. Well, Dr. Bell and a physician at Legacy Salmon Creek will take care of educating, and this is being simultaneously educated to you and to the ED docs. The ED docs have seen this before. This has been in the literature, and yes, some of us read, so you will see it. But we will be educating them that they will be coming in, so they will not give you grief. Well, I apologize if they do, because we won't get to everyone, just like I don't get to every medic in the county every minute either. But we will re-educate them after the fact if that's the case. Just smile and say, this is in my protocol. You can show them the protocol if you want. We will educate them. We will take care of that. The most important part of that equation is that when you have a patient, a guardian refusing transport, you need to be on, the ED doc needs to be on the same page that you are when they're talking to the family. So we will take care of our end of that, doing that education. Now, remember, this is a group of symptoms, not a disease, generally seen in infants under 1 year of age. It can occur up to, it says 2, an earlier slide said 3, let's say 2 to 3 years. It's uncommon beyond beyond a year. Most patients have a normal exam by you, but underlying causes can include pneumonia, bronchiolitis, seizure, sepsis, intracranial hemorrhage, and meningitis. Kind of things we want to rule out. Up to 10% of these patients will require intervention in the hospital, either in the ED or in the pediatric unit. Okay. Any questions up to that point? Is it clear, crystal clear, as they say? Okay. Now, we will, you guys are getting it will be in the protocol. Hopefully tomorrow you won't have a case that you have to call the ED for. Might happen, but this protocol could be in effect at this time. We have had ALTI cases, and we have one in case review, so we'll get to that. So they do occur. So this is to give you, I guess the point is if the parent or guardian is worried for something, this usually means that something did happen. So now on to restraint of patients. Talk a little bit about Haldol, haloperidol. And the reason we're talking about this is because although my favorite drug is an napsine, you can't get an napsine right now. There's no point in worrying about it if you can't get it. I mean, it's a drug thing. It's a drug supply thing, and nobody can get it apparently. Haldol is a good substitute. Haldol is one of the sedative drugs that has been used for a long, long, long time. As a matter of fact, it's the favorite drug of the emergency department in Denver, at Denver General, where they get all the really aggressive. And the rule with Haldol, starting about in 1970, when Haldol first came out, was that if the patient was aggressive, if the patient was hitting the nurses, cursing the nurses, spitting at the nurses, doing anything that the nurse didn't like, they got 5 milligrams of Haldol IM. If he continued, you did 5 milligrams until they were nice. And the average at that point was getting about 30 milligrams of Haldol, where at most people, even rather large aggressive folk on amphetamines, in those days it was just straight amphetamines, meth hadn't been invented, they would sit up in bed to yell or to hit at you, and then they'd pass out because they had orthostatic hypotension from that much Haldol. That keeps people down at least. Haldol is a butyrophenone derivative. It has antipsychotic properties, and it's particularly effective in managing hyperactivity, agitation, and mania. Obviously, was developed first to take care of schizophrenics who were manic, or any manic person. It does have antiemetic properties, although we don't recommend it to control nausea. We have other things to control nausea. It has, however, a tendency to provoke extrapyramidal effects. It has weak, although present, alpha adrenergic properties, which causes the hypotension. Alpha adrenolytic properties. It knocks out your alpha. So enough Haldol will make any of us hypotensive. It also has, like all drugs in the butyrophenone category, like almost all, like a napsine, any of the antipsychotic drugs have QT prolongation properties. If you prolong your QT, you have the chance of going to a torsades. That's the worst endpoint. Now, the safety factor on that is that unless you have a tendency toward QT prolongation, in other words, congenital prolonged QT syndrome, or you're on other medications or other conditions that already prolong your QT, there's really no worry on the dosing that we give. But because you have the potential for QT prolongation and the potential for torsades is why whenever you use any of these drugs, you have the patient on a monitor. You have the patient on a monitor so that you don't have to say, oh, I was just watching him, all of a sudden he twitched and had a little seizure and I didn't know what was going on. And then when we finally hooked him up to the monitor, he was in a torsades. I want you to know that he goes into the torsades quickly, you know. And also, if you're really, really, really good and you study, and Mike Hollingsworth teaches you how to read QT prolongation in a tachycardia, then you can predict it. So, precautions with Haldol, same, use it in reduced doses if there's renal or hepatic impairment. The elderly all have a little bit of remember, those are older than 72. They have a little bit of a decreased renal function anyway. They have decreased liver function anyway. Hypotension can occur if you give it. That's not a bad problem if you got the patient laying down on a gurney anyway. You can't have QT prolongation and torsades in the susceptible patients. CNS depressants they are potentiated, so narcotics, if you give it along with a narcotic such as morphine well, you don't have morphine, so give it with fentanyl that will potentiate the fentanyl. If you give it with Versed, it potentiates it, which we're going to use for our advantage in a minute. And you can get extrapyramidal symptoms. The worst things are dystonia and tremors, dystonia, inability to walk. They can have the severe case is oculogyric crisis. Their eyes seem to get stuck to the side. They're not having a seizure. They're awake. Their neck twitches. They feel terrible. They know they're going to die. Akathisia is the most common thing, and maybe due to, in my experience, it's due to not giving quite enough of the Haldol or anapsine. Anapsine is very common to get akathisia. Akathisia is that I just don't feel good, creepy, crawly, icky feeling that they will describe. And that's a little harder to cure actually than it's really great to get the guys with the oculogyric crisis because you give them a little Benadryl and all of a sudden they get well and they think you're God. Akathisia doesn't always go away that quickly. Sometimes you have to kiss them with a little Versed along with the Benadryl. Now, why do we use Haldol or anything like it? Okay, sedation to facilitate restraint of combative patients in emergency situations. Contraindications, people who are allergic or have a known idiosyncratic reaction. So if somebody, or an EPS kind of reaction. So if the patient says, if the patient's sitting there calmly enough to tell you that, oh, I don't really want to take anapsine or I don't want to take the Haldol, odds are in this community they probably haven't had Haldol in emergency situations. We've used anapsine for years, so they're probably relatively virginal to Haldol. But if they tell you they're allergic, ask them what they mean by allergic. And they'll say, oh, I felt all creepy crawly. Well, it's probably not a good idea to give it to them then if they have the creepy crawlies. They'll probably get it again and they'll be mad at you. If they have known congenital QT prolongation, if they have Parkinson's disease, well, they've already messed up their extrapyramidal systems, already messed up. Why mess them up more? Severe metabolic derangement, hypokalemia, hypomagnesemia always contributes to prolonging your QT. So when you go into the place and you have an agitated, skinny person vomiting in the corner, and they're still agitated and hitting at you, and there's Karen Carpenter music playing in the background, don't give them Haldol, okay? Don't give Haldol if you don't have any Benadryl, and we do run out of Benadryl sometimes. Have to look in your box, drug box. And if you don't have them on a monitor, or you can't put them on a monitor, don't give them. You don't have to put the monitor on immediately, that moment, but shortly thereafter. So we'd like to give it IV if possible. IV established. Give Haldol 2 to 5 milligrams IV or 5 milligrams IM. Higher dose IM, it takes longer to get in, it takes longer to take effect. You can repeat every 15 minutes to a total of 10 milligram max dose, either way. Children get a dose of 0.1 milligram per kilo, but not to exceed the adult dose. Now, we're going to talk separately about excited delirium, but in excited delirium, you can give Haldol 10 milligrams along with Versed 10 milligrams IM. You can also use Geodon instead of the Haldol, but we'll talk about that. If you have with Haldol, if you have extrapyramidal symptoms, dystonia, akathisia, oculogyrate crisis, Benadryl 12.5 to 25 milligrams. I'd take 25, thank you. Children, 1 milligram per kilo IV or IM. Patient must be monitored on a EKG. Record and monitor vitals and EKG after administration every 5 minutes, looking for hypotension. If hypotension occurs, simple fluid challenge. If you got excessive Haldol and excessive hypotension, because it's an alpha adrenolytic drug, you give it an alpha drug would be nice. Give them back a little epi drip. If QT prolongation or wide complex, treat by protocol. What do you treat wide complex tachycardia or torsades with? MAG. So, now, we restrain patients because the patient's a danger to self or responders, you. Sedative agents are needed to restrain violent patients, but you need to evaluate them. How many people do you need to take down a combative patient? Safely 4, but 5 is an ideal number because it's always good to have somebody on the head. So, treat the medical causes of combativeness. So if the patient's hypoxic, treat that. If they have head injury, we don't want to necessarily give them sometimes we have to restrain them chemically. Treat hypoglycemia. That's an obvious thing. We don't want to give somebody max dose of Versed and Haldol if they're hypoglycemic. That looks very bad on the record. And then think about excited delirium, which is sort of beyond the pale of agitation and violence. So your procedure, once again, is actually more straightforward than it appears as we read it. If the patient, you have to evaluate why you think this patient is agitated and needs to be chemically restrained. So you've gone through the process. You say he's agitated because he's psychiatric. He's an agitated schizophrenic in a manic phase. He's stopped his drugs, whatever. And if it's psychotic, we treat it with Haldol. So you give Haldol, IV or IM, repeating up to the max dose of 10. And the alternative of that is Geodon, 10 milligrams IM only. It can only be given IM. That's what makes Geodon a nice drug for really agitated delirium. It can only be given IM, and you can often get only you can't get an IV started in these guys. Now, if they have EPS, Benadryl 12.5 to 25, and if they had the akathisia and you needed to give them, if they're still agitated after 10 minutes, give them a little kiss of Versed. Now, if, however, you think, hey, this guy is just a meth head. This guy is on coke. This guy is on a combination of everything. And this is drug-induced agitation. Then start out with Versed and 2.5 to 5 milligrams IM or IV. Obviously, the higher dose IM. And you can increase that, then you can repeat up to a maximum of 10. At that point, if you've done the max dose, let's say you thought this guy was just simply psychiatric, you've done your max dose of Haldol. What's the max dose of Haldol? 10. And he's still wacky and trying to take you out or trying to harm himself. Switch now and give him the other category of drug. Give him some Versed, and you can give him up to the max dose of Versed. But you do the max dose of psychiatric drug first, and then switch to the sedative, true sedative. Now, if it's the other way around, same difference. If you had given him you thought, oh, he's the drug overdose, he's a meth head, I gave him my full 10 milligrams of Versed, and he's still uncontrollable, then give him some of the Haldol or Geodon, which is depending on what you're carrying. Hopefully you're carrying only one and not both. Because you don't give them Haldol and Geodon together. Use one butyrophenone derivative, one psychiatric drug, and one